A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, let me introduce you with the housekeeping rules. The webinar link will be available from 9:15 a.m. to 9:45 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And these CPD points are strictly adhered to the NCCPD guidelines. And you can ask the questions at the end of the webinar by typing on the chat box. These guidelines are to improve and maintain the standards of the CPD programs conducted by Shri. Thank you for your strict adherence and kind compliance. So today our topic is overcoming challenges of breastfeeding. The guest speaker for today is Dr. Nishani Lucas, consultant neonatologist, University Unit, the Soysa Hospital for Women, and senior lecturer at the Department of Paediatrics, University of Colombo. Over to you, madam.
Very good morning to you, and thank you for that kind introduction. So today I'm hoping to talk to you about overcoming some challenges of breastfeeding. So I'm hoping to break it down into sections: why we should support breastfeeding, why we should say no to formula, and what are the challenges we encounter in the postnatal ward, neonatal unit, and some breast conditions that we may see in our practice as well. So we will first start off with why we should support breastfeeding. So first and foremost, all children have rights, and we in Sri Lanka are also signatories to the UN Convention on the Rights of the Child. And even in the Declaration of Rights of the Child in 1959, under good nutrition, breastfeeding is a right of the child, as well as its later Convention on the Rights of the Child from 1989, in which Sri Lanka is also a signatory, under protection and under the right to protection, as well as the right to develop to its full potential, we as medical personnel are bound to ensure that we are there to sort of support the rights of the child. Then again, something we must remember is that children are not the property of its parents. So just to keep the parents happy, we should not go along with the parents' sort of suggestions if it is not in the best interest of the child. Then again, just like there are rights of the child, there are parental responsibility as well. And included is it is the responsibility of the parent to protect and maintain the child. So therefore, it becomes the responsibility of the parent to ensure the child obtains the best nutrition, and it's a right of the child to obtain the best nutrition. So why are we talking about breastfeeding? Increasing breastfeeding worldwide prevents 800,000 child deaths per year, as well as it saves 20,000 mothers from breast cancer. And it has also been shown that exclusive breastfeeding up to 6 months of age, as well as breastfeeding up to 12 months of age, was the number one intervention which was successful in preventing childhood mortality. So all of us who are working towards minimizing childhood mortality and improving morbidity, it is very important we are armed with the skills how to support any woman to breastfeed their child. So this is part of the study where it shows that exclusive breastfeeding was the most effective intervention, whereas continued breastfeeding along with complementary feeding was the third effective intervention. Here we can see different mammals from the animal kingdom, of which we are also part of, and we are also mammal. But it's interesting to note that each of these mammals are feeding their own species. You do not see cross-species feeding. So is it appropriate what we do to take another animal's milk and feed a human child? So that brings us to the question, are all mammal milks the same? So if we have a close look at it, you can see that they are quite different. And if you carefully have a look and see which is the milk that has the composition that is closest to the human. So if you look at it very carefully, you would see that it is not the cow. but it is the monkey that has the more similar milk to humans. And why would that be? What do we humans and monkeys have in common? So that brings us to evolution, described by Charles Darwin, isn't it? And we are most closely related to primates and monkeys. And that we think it may be due to the brain growth. So that brings us to the question. So this milk is species specific. We can see that because each type of milk has different compositions. For example, you can see seal milk, very high in fat, and that is adapted to the fact that they live in very cold countries where they need to protect themselves from cold, which needs a huge fat layer. Again, cows have quite a lot of proteins, so which means they need it because the calves can walk soon after birth. Humans, on the other hand, whatever we feed cannot walk soon after birth. It takes a good 1 year or more for that to happen. But our most sensitive period of brain growth is within the first 2 years of life. And in order for that to happen effectively, we need to make sure that they give the optimal nutrition from the milk. So, mammalian milk is in fact species specific. So, it's not as simple as taking some other animal's milk and giving it to a baby. Yes, it is milk, all right, but it will not have the ingredients to ensure that the species, that it's specific for that species growth. So, if you give cow milk, baby will get everything needed for optimal cow growth. But if you want human growth to be optimal, it's important to make sure that we give human milk. It's very sad to see that although we think we are the smartest among species, that it's only us who feed our kids with milk from other species for no good reason most of the time. So that brings us to the question, as I mentioned earlier, I said our milk is closest to monkeys and we are at sort of the top of the animal kingdom, or so we think. So breastfeeding actually increases the IQ by 7 to 10 points. And just looking at all the skills that we need to survive, we could see that the foundation for skills of vision, hearing, emotional control, concepts, peer social skills, language, number skills, the foundation is within the first 2 years. We call this the first 1,000 days of life. This is where from conception to the completion of 2 years. This is the most sensitive period for brain development. So it's important the child gets all the stimulation they need, as well as optimal nutrition in the form of exclusive breastfeeding for the first 6 months, followed by good quality complementary food, continued breastfeeding. So does breastfeeding improve IQ? Do we have evidence to say this? Yes. There's a lot of work done, and over the years, which have shown that breastfeeding is sort of the only food in the world that can actually improve the IQ. So this is a little cartoon for you to see that, this guy has not done well in the GCSE and blames it for not being breastfed because, of course, his IQ would be 7 to 10 points lower than somebody who was not breastfed. So can we actually see structural changes, physical changes in the brain? Yes. The white matter volume is increased in a baby who has been breastfed. Not only is the volume increased, but also the structural organization is increased. So there are actually physical changes if you look at the brain. And there's a lot of work done on this and many papers published. It also increases the myelin content. You can see that the myelin content increase is proportionate to the duration of breastfeeding. And the effects of improved IQ does not last only through early childhood, but throughout life. So one reason we need to breastfeed our babies is to ensure that they have optimal brain growth. This I'm sure we all know. It protects against disease, but how much? Again, if we look at the thymus is larger in breastfed babies and smaller in formula-fed babies. We all know that antibodies cross through the breast milk and Not only is it antibodies, but there are many, many other components that protect the baby against infection, against all types of microorganisms, as you can see. And it is not only against microorganisms, but also against tumor cells because of the alpha-lactalbumin, as well as in case this baby needs transplantation in the future, there will be better acceptance in organ transplantation in a baby who is breastfed. So you can see it is different chemical components that are transferred, including cells. Due to all these immunological factors that the baby gains, it can be described, it has been described as a vaccine which is 100% safe and effective. Again, we know that it reduces acute illness, but are we aware of the impact? So within the first 2 years, it reduces respiratory illness by 72%, diarrheal illness by 64%, ear infection by 50%, as well as necrotizing enterocolitis and sudden death. It reduces allergy. I mean, it's pretty obvious because we are exposing the baby to something that is ours versus something that is foreign to the human body. So asthma, atopic dermatitis, allergic rhinitis, all would be less in a baby who is breastfed compared to a baby who is formula fed. It improves the gut colonization because breast milk contains friendly bacteria versus formula milk, which contains unfriendly or pathogenic bacteria. So whatever reaches the baby first would be the colonizer. And whenever time we give formula milk, there's a high chance that the baby can be invaded by these unfriendly bacteria, providing baby's immunity is low. Breastfeeding also helps the jaw growth as well as the airway growth because of the mechanism and how the baby suckles on the breast. It also reduces malocclusion, which is a problem and very costly problem as well. It reduces leukemia. Here you can see the impact. The commonest type of leukemia, ALL, is reduced by 1.3-fold, whereas AML or acute myeloblastic leukemia is reduced by 1.2-fold. So early programming is something that would determine the effects of what we feed the baby lifelong. Breast milk affects early programming by altering the microbiome and altering epigenetics, and thereby it reduces the risk of obesity, diabetes, heart disease, multiple sclerosis, ulcerative colitis, Crohn's disease, so on and so forth in the adult as well. So breastfeeding reduces obesity by 26%. It reduces type 1 diabetes by 39%, type 2 diabetes by 27%. So for a mom who has diabetes, the best thing she could do to reduce the risk of transmitting or their baby will have a genetic risk, but something to negate it or to counteract it would be to breastfeed that baby. The risk of heart disease, hypertension, hypercholesterolemia will all be reduced with breastfeeding. And not only are there advantages for the baby, but there are also advantages for the mother. As I mentioned earlier, it reduces the risk of cancers, mostly breast cancer, but also ovarian cancers, endometrial cancers. It reduces anemia, reduces the insulin requirement, hence very useful for moms with diabetes. It improves the bone health, lowers the risk of depression in the mother. It has a contraceptive effect for the period where the baby is exclusively breastfed, and it helps with weight loss, regaining the pre-pregnancy body shape, and it also increases bonding between the mom and the child. So these are some of the reasons why it's important to ensure that babies are exclusively breastfed for the first 6 months of their life, or at least 4 months. If it is difficult to go until 6 months due to, say, mom working or growth faltering or whatever. So if we summarize what we talked about, why should we breastfeed? It's the right of the child. It improves survival, improves IQ, improves jaw development, reduces acute infection, reduces cancer risk, malocclusion, asthma. And it also puts the foundation to becoming a healthier adult by reduction in the risk of obesity, diabetes, hypertension, hypercholesterolemia, immune-mediated disease. And there are a load of maternal benefits, including reduced risk of cancer and reduced risk of obesity in the future. So why say no to formula? We all know now we are not going to get the benefits of breast milk if we start formula. But are there other problems as well? Is it safe to begin with? So there's this poster and many other posters done by the Family Health Bureau, which describe, so this is a local poster, the 21 dangers of infant formula, where you can see most of the things I discussed are given here, problems for the mother, problems for the child, and it's also economically not advantageous to not breastfeed. Other than for the formula companies, nobody else benefits. It is a problem for the child's going to get sick, more expense for the family who needs to stop work and be with the child in the hospital, more expense for the health sector. So it's going to cost the global economy around $302 billion every year. Is formula feeding worse than smoking? We all know smoking is bad, but do we know how bad formula feeding is? Because all the media that we are exposed to will just sing the glories of formula milk as with good advertising campaigns. So people who smoke more than 20 cigarettes per day are 3 times more likely to get a lung infection, whereas those who are formula fed are 17 times more likely to get a lung infection. Those who smoke 20 or more cigarettes, IQ drops by 7.5 times, whereas children who are formula fed, now we know, IQ would drop by 7 to 10 points. Again, children who breathe secondhand smoke have more ear infections, similar with formula. Smokers are twice as likely to get Crohn's disease, whereas formula-fed babies are nearly 4 times likely to get Crohn's disease. And the list goes on. And did you also know that the children who are formula-fed are at high risk of infection with Enterobacter sakazaki? This has caused mortality and morbidity. And this is especially a problem when the milk powder is used for formula instead of the liquid formula. So this was a label that came on formula following the death of children and severe morbidity following meningitis, which was there for a couple of years following a lawsuit. So you can see it says that it's not sterile, they are contaminated with heat-resistant and pathogenic bacteria, and it is linked with a high mortality rate. Here again, you can see formula being thrown. Can imagine how expensive formula is and what would lead people to throw it. This is from China in 2008, where children were sick and some children died. Children were affected with renal failure in 2008 due to melamine, which was added to formula to increase the protein content. So you can see a clip of a newspaper where the babies were found. The formula was found to have melanine, where 6 children died and thousands were hospitalized with kidney damage. So you can see formula is an industry and it doesn't necessarily look after the well-being of the consumers. Formula has not undergone any clinical trials for the safety at the time it came out in the 60s and 70s. And in Sri Lanka in 2013, DCD was found. And that's a time when all the powdered milk went off the shelves. But again, because of the economic stuff, it came back after a little while. So here again, and that brought the New Zealand Prime Minister down to Sri Lanka to talk, because we are their 5th largest market. So if we go out of their sort of marketplace, it would be a very big disadvantage for them. So we know that formula is not a good alternative unless we are really, really pressed against the wall, let's say with the maternal death, or in a condition where it's detrimental to the mother to breastfeed. In all other conditions, it's very important that we try our best to support, to feed these babies. So the biggest problem why mothers turn to formula is that we are unable to support them, and with the heavy advertising of the formula industry. So mothers need support. Women are not born with the inherent ability to breastfeed just because we are women. So we need, as the health professionals, we need to be able to support these mothers. So next, we are going to talk about what are the challenges we face, most commonly in the postnatal ward. So how do we provide support to breastfeeding in the postnatal ward? It's important that the postnatal ward staff are educated. So doctors, nurses, midwives, attendants, everybody who surround patients. So it's very important to support the challenging situations. So supporting breastfeeding should not be allowed for the decision should be the consultants, and the doctors should make sure that every baby is breastfed. So how do we ensure that breastfeeding is established prior to discharge? What happens if, so some challenges when people start formula, when there is no urine output, when there is jaundice, when there's hypoglycemia. So let's have a look and see what happens. So how to ensure that breastfeeding is established before discharge? It's important to measure the weight daily, calculate the weight loss and gain daily, and calculate the weight loss percentage, as well as assess the breastfeeding technique. So if the weight loss is less than 5%, and if the breastfeeding technique is satisfactory, we can discharge the baby and can be reviewed at home by the public health midwife. If the weight loss is more than 5%, we have to support the breastfeeding, check the weight daily, check the trend. And if the weight loss per day is decreasing and the breastfeeding technique has improved, we can discharge. So it's important to make sure the weight is measured and this is calculated by the doctors before we discharge a baby from the postnatal ward. Right? So just because the neonatal examination is normal, that should not be criteria to discharge. We should make sure that the mother and baby are armed with the skill of effective breastfeeding. And if the weight loss is more than 10%, it is important to review these babies in your lactation management center as well as your clinic within 1 week. So let's look at an example to see what this really means. So the birth weight, if it is 3 kilograms, the day one weight is 2.9. The weight loss is around 100 grams. And if we divide this by 3,000, which is the birth weight, we get the weight loss percentage as 3.3, which is less than 5%. We also see that the breastfeeding technique is satisfactory. And then this baby is, yes, ready for discharge with regard to breastfeeding. Let's look at another example. So another example would be a birth weight is 3 kilograms. Day one, baby is 2.8. That's 200 gram weight loss. And the percentage is 6.6. And the breastfeeding technique, which has been observed, states that attachment needs improvement. So this mother and baby needs further help. And the help does not happen by going home and relaxing and putting the legs up. No, that never happens. And they need professional help, whatever the category of staff or layperson. So we should not discharge this person. Then we support and we review the next day. On day 2, we see the weight is 2.75. So 50 gram loss compared to the previous day. But if we look at the total loss, because the loss is continuing, the weight loss percentage has gone up, but the loss per day has gone down. And when we see the breastfeeding technique, we see that it is satisfactory. So since the weight loss is less than the day one loss and the technique has improved, we can discharge this baby and review this baby again. So what is the science of this 5%, right? So it first appeared in the neonatal edition of Archives in 2013, where they had found that more than or equal to 5% loss predicted the eventual more than 10% loss. Then I conducted a study in our unit as well, where we found the same findings. And we presented these at one of our annual sessions. And we also found that more than 5% weight loss was associated with poor breastfeeding technique. And how many people need support? So a lot of people, at least 1/3 of the mothers over 34 weeks needed lactation support. Then I mentioned that we look at the weight on discharge. So every baby in our unit is measured daily around 5 o'clock in the morning by the nurses, and the doctors have to interpret this weight as to the weight percentage or the daily weight loss. In addition to that, every mother and baby pair is assessed by a nurse from the lactation management center. It doesn't have to be lactation management center. It can be a postnatal ward nurse who does the assessment, but document what the breastfeeding technique is. So here you can see positioning good, attachment needs improvement, suckling pattern good, and overall there is poor attachment. So these sort of babies, we are not going to discharge this day, but we will give support and review on the next day. And then we will take into consideration both the technique and the weight loss before we decide the discharge. So what is this positioning, attachment, and suckling pattern? I'm sure you all know. But just to remind ourselves, right? So it can be any of these positions. Baby's head can be supported by the hand or by the elbow, or it can be underarm positioning. But whatever it is, head and neck should be in one line. Baby should completely turn towards the mother. and baby's neck should be supported and head should not be pushed into the breast. And if these criteria are fulfilled, we say positioning is satisfactory. So we need to wait until the baby's mouth opens wide before we attach the baby. So we need to advise this to the nurses who are helping, or the midwives, as well as the mother, right? So it's customary that people try to sort of get the baby to open the mouth by pressing the nipple on the mouth. That is not good, because they don't open the mouth well. You have to wait till they are hungry, till they open the mouth wide, and then you attach. And when they attach, the whole or most of the areola should be inside the mouth. More of the lower areola should be inside the mouth. And their mouth should be open wide with a ah mouth, not a oo mouth. So why is this attachment so important? Because once the areola is in the mouth, there is a vacuum created inside the closed mouth, and that will draw the breast tissue inside, and the nipple will touch an area at the back of the palate near the junction of the soft and the hard palate, and that in turn will elicit the sucking reflex in the baby. So baby will keep on sucking until he is full and then let go. If not, they will just try to suckle on the breast a little while, and they will damage the nipple area, causing cracked nipple. So the mother gets injured, then the baby doesn't get milk, and it is a no-win situation for both parties. Why do we say don't use pacifiers, don't use teats, don't use the bottle to feed? That is because it is different. The technique is different in how the baby suckles on the human breast, where you can see the breast tissue is inside, filling most of the mouth, and the nipple stimulates sucking reflex at the back of the palate, whereas what they do with the bottle teat is quite different, and only the anterior part of the mouth is involved. So if we summarize the technique of breastfeeding, positioning, the baby body should be in straight line, support the nape of the neck, do not press on the back of the head. Baby should be completely turned towards the mother. So why do we say do not touch the back of the head? Because we can press the baby onto the mother, and there's a risk of suffocation. The mouth should be wide open. It should be ah mouth versus a oo mouth, and most of the areola should be inside the mouth. There should be a rhythmic suckling pattern where the baby will suckle 1, 2, 3, and there would be a pause, and the pause is actually for swallowing. So sometimes mothers believe baby has fallen asleep and they touch the cheek. If you touch the cheek on top, it elicits rooting reflex, and the baby turns away from the breast. And if we flick the heels or press on the ears, that will disturb the baby, and some babies would get irritated and get away from the breast. So the next question would be, when should we put the baby on the breast? It's not like the baby can talk. So how do we know baby is hungry? Baby would show what are called hunger cues. And it should not be 2-hourly feeds or 3-hourly feeds. We should not be keeping the alarm or looking at the watch and doing it, because each baby is different, like you and me. So usually it would be every 2 to 3 hours, but it can vary because, again, stomach capacity is different. Frequency of feeding decreases with age. And why would that happen? Because the baby's stomach capacity will increase with age, and therefore they will be able to retain more milk at the same time, and they will become more efficient. So they will be able to quickly gather all the milk they can. So the duration of feeding will go down, and they will not be hungry for a longer time. They would sleep or be happy for a longer time and be satisfied. So the breastfeeding should actually get spaced with time. So here I'm going to show you some of the hunger cues. Here you can see a baby putting the hands in the mouth, opening the mouth wide open. Crying is not a hunger cue. So frequently we say andana kota kiri denna, but that is not what should happen. We should feed the baby before the baby starts crying. So when the baby is looking around, putting hands in the mouth, opening mouth, that is the time that we need to feed the baby. Crying is too late, and usually the baby starts making a fuss and may refuse. So it's much better if we can get to feeding before the baby starts crying. So it's important that baby is actually kept in a cot where the mom can actually see the baby. Here again, you can see another baby showing hunger cues, opening mouth, putting hand in the mouth. Again, sleeping babies, we should not wake them up for feeds just because the time is up or you are worried it is going to. Babies don't just become hypoglycemic like that. So there is no justification to wake sleeping babies up. They just become irritated and they will refuse to feed. How long should a baby feed from the breast? So it is until the baby comes off. It's usually would range between 10 to 15 minutes. And once the baby is bigger, it may even be 3 to 5 minutes. It will vary between babies and it will vary on the same baby as well. So usually initially they'll take about 10 to 15 minutes to feed on the breast and then they will let go. So there is this saying, you need to feed 20 minutes from the breast. That is not right because one number does not feed all. How will the mother know that the feed is over? Because some mothers keep putting the baby back to the breast. So the breast will be heavy in the beginning and the breast will feel light at the end of the feed. So if the baby has emptied the breast, there's no need to put the baby back, whatever the time. How do we alternate between two breasts? So if one feed is given, let's say through the right breast, the next feed should be given with the left breast. And each feed should be given only with one breast. And you alternate the breast between the feed. You should not alternate breasts during one feed because the first bit of milk is foremilk, which is rich in water. The last bit of milk is hind milk, which is rich in fat. So if you alternate the breast too soon, baby will only get the water component from both breasts. Then what do we do? Sometimes we are told that baby has not passed urine within the first 24 hours. So we usually expect the baby to pass urine on day 1, once a day, 2, twice a day, day 3, thrice a day, etc. And it takes about 5 to 6 days to reach the more than 6 times per day. So after baby's 5 to 6 days, they will pass urine more than 6 times a day. But until that time, it is equal to the day of life. So on the first day, if it passes urine once a day, it is more than enough. Even if it does not pass urine, make sure, especially if it's a male baby, that we are not missing a PU valve. Make sure the bladder is not palpable. And all we need to do is support breastfeeding. You no need to do renal function tests, no need to scan, no need to put IV fluids, no need to give formula. Just support breastfeeding and watch for the next day. And almost all babies have passed urine. I have never come across a baby who has not passed urine. So a top-up formula feed should be given if no urine output is false. Right? Now, what happens with jaundice? So we know that there are elements in breast milk that cause jaundice, yes, and delay in establishment also causes jaundice. So we need to make sure that breastfeeding is going well to reduce jaundice as well. So sometimes if the bilirubin is very high and it's near or above exchange level, we have to make sure baby spends maximum time under lights. So we express the breast milk and give it through cup. And as the bilirubin comes down, and we can be more liberal with the time at the breast, because that means baby is not receiving the phototherapy. So if we get a Billy blanket or the fiber optic blanket, we can sort of, continue with this. But at the moment, we don't have it in the state sector. So if the bilirubins are high near or exchange level, we would keep the baby under lights and express breast milk and feed with the cup. So these are the charts we are using. These are in the neonatal 2020 guidelines. These are the nice charts. So as I mentioned, if the red mark is the baby's bilirubin, so if the baby's bilirubin is near exchange, we would express breast milk, and that would be fed by the nurses while the baby is still under lights. Whereas if the bilirubin is still above phototherapy but not near the exchange level, we can allow the mother to breastfeed the baby for about 10 minutes directly from the breast and then put the baby back under the lights. So the main concern is not that the breast milk is bad, but we need to keep the baby under lights. And when the baby is under lights, the mom can't crawl under the phototherapy machine and feed. So that's the problem. So we take the baby out for a limited time and put the baby back if it's just above phototherapy. So should breastfeeding be withheld if the baby is jaundiced? No. It should be continued and the mother should be supported to breastfeed. So what happens with hypoglycemia? Again, a lot of people get scared and start formula feeding in hypoglycemia, but that is not rational at all. So what happens? So when the baby is separated from the placenta, you can see there are changes in hormones with increased catecholamines, cortisol, glucagon with decreased insulin, and they will have glycogenolysis, which produces glucose in the first 12 hours, gluconeogenesis from 2 hours, and they will have high ketone turnover after 12 hours for 2 to 3 days. So these are the things that are going to help the baby to adapt. So the energy for brain metabolism is coming 70% from glucose, but that is not the only source, right? As long as the baby is fed breast milk, there will be 30% from alternative substrates, which include ketones and lactate. So enteral feeding has to be continued because that is the stimulus for postnatal metabolic adaptation. So even if we have to start IV fluids, let's say for symptomatic hypoglycemia, we have to continue the breast milk as well. So high circulating level of ketone bodies have been seen in breastfed infants. And therefore, even if the blood sugars are marginally low, the ketone bodies in the breast milk protect the brain in babies who are breastfed. But remember, there is no ketone bodies in formula milk, so they do not get any protection from formula milk. And there is no basis to start formula milk for hypoglycemia or risk of hypoglycemia either. It is just lack of knowledge and lack of scientific rationality. So breast milk is the enteral feed of choice to prevent and treat hypoglycemia. So formula top-ups are indicated if the baby gets hypoglycemic is absolutely false. Then we have spoken about babies in the neonatal unit. We have spoken about babies in the postnatal ward, how to discharge, and how to encounter some problems like lack of urine output in the first 24 hours, jaundice, and hypoglycemia. Let's have a look at what really happens in the neonatal unit. So should we exclusively breastfeed preterms? Does it meet the nutritional requirements? And what should we do if there's poor weight gain on breast milk? So should we exclusively breastfeed preterms? Of course, the answer is definitely yes. Human milk is undoubtedly superior. It reduces most of the things. It reduces the risk of things that kill them, like necrotizing enterocolitis, late onset sepsis, and it improves the neurodevelopmental outcome. It is more nutrient dense and it has higher content of proteins, fats, energies, and certain electrolytes. And you would see a change of things over time because they will need less protection and more energy as they survive over time. Can unfortified breast milk provide enough energy? Of course, yes. There is about 65 to 70 kilocalories per 100 ml in breast milk. And if we provide this at 160 to 180 mils per kg per day, obviously not on day 1, but around day 5 to 7, this will give them the necessary protein energy requirement. And the expected weight gain would be 10 to 30 grams per day. And we need to add minerals and vitamins because we know that, breast milk is not the best method to get calcium or phosphate. We need to add calcium phosphate supplements for preterm babies if necessary. So to maximize the energy from preterm milk, we must make sure that the woman empties the breast. So you must never tell mothers, give me 1 ml, 2 ml, because they will express the first 1 to 2 ml, which is water. And you can see the first tube, this one is water. The fore milk, and the one that is thicker with the yellow lid is the one which has the hind milk. So we ask them to express milk into different containers as their volume increases. And we start by, don't ask them to throw any milk out. We start with the last cup they express with the hind milk. And depending on how much the baby tolerates, we will try to give them everything that the mom express, but start from the milk express last and then go to the milk express first. So until recent times, people thought that weight gain was everything, but now we know much better. Weight gain, you need to look at the quality of weight gain because weight gain can be fat or fat-free mass. Especially preterm babies and growth-restricted babies are at very high risk of metabolic syndrome because they are more prone to develop more fat and get more cardiac disease, obesity, and metabolic syndrome later. So using breast milk instead of trying to pump up weight gain using formula just for us to make us feel better is not good for these babies at all. Neurodevelopment was found to be better with breast milk despite suboptimal weight gain. So we have to get away from the obsession of seeing weight gain. So this is a growth chart of a 32-week-old baby who was born at 1.25, and you can see all we need to do is actually to go along the parallel to the lines on the growth chart. What about fortifier? So fortifier is not indicated in our setting for most babies unless there's a restriction of volume. For example, a baby in heart failure and the cardiac surgeons are not happy to do the surgery but want to wait until a certain weight, and there is a restriction of volume where we can't go up to 160 to 180 mils per kg per day, then yes, there may be a place. Although this is called human milk fortifier, this is actually made up of cow's milk proteins, and I'm sure the name is to sort of confuse us. It is milk fortifier for the human, but it is not usually made out of human milk. In the laboratory setting, yes, there have been instances where the milk fortifier has been made of humans, but what is available to us commercially is usually the cow's milk. So obviously, the problems are similar to what will happen when we give the baby formula. And the nutrient enrichment is only 10%. So standard fortification is what is usually done where, some fortifier is added to the milk. Individualized fortification is much better, but that is where the milk is measured and you are individually fortifying each baby to what that baby will receive. But this, as you can see, will not happen in our setting or even in a neonatal setting in any country almost, other than maybe for research purposes. So individual fortification, whereas it is better, standard fortification is what happens and is very, very problematic. So although in the West and during our foreign training, we see many people using fortifiers, that doesn't mean we blindly come and do everything that we have seen in the West. You take the good things and leave the bad, because some things we are actually doing better. So body composition of preterms fed fortified breast milk is different. They have more fat mass in them, which means they are more likely to die early of heart disease. The amino acid profiles are different. So just adding fortifier blindly just because the West does it is a very, very wrong practice. So again, you can see there's low quality evidence that it even increases growth. And we have to be careful because fortifiers are distributed, manufactured by the same formula companies who want to give formula as well. So obviously the interests are vested. So again, I have put a long list of problems by giving fortifier, which is similar to problems when giving formula. Slower gastric emptying, increasing the chances of necrotizing enterocolitis, increasing reflux, neutralizing some of the anti-infective properties. Enterobacter sakazaki is a problem again, increased infection, increased contamination, increased allergy. Breast milk does not provide sufficient nutrients for preterm babies. It's false. Breast milk provides sufficient nutrients, but we have to make sure we support the mother to make sure that she gets adequate amount of milk. So can we exclusively breastfeed? Yes, we have to make sure we do that, but we have to make sure we educate our staff and have a good culture where the other staff members say the volume is important and breast milk is adequate for growth. We have to support the mothers, ensure there's frequent contact between the mother and baby, and help the mother to get adequate milk supply. We should have no formula, no bottles, no pacifiers in our neonatal units. How soon do we feed the preterm babies? As soon as possible. So we have to target to do this within the first 6 hours because there is no evidence that delayed introduction reduces the risk of necrotizing enterocolitis, but some people still are scared to quickly start breast milk and increase. So again, a recent study done by one of my colleagues showed that breast milk, which was started on day 1, so some mothers send it on day 1, some mothers don't send it on day 1. So this is how we managed to look at it. But you could see the outcomes were markedly better on babies who started on day 1. So these mothers who deliver preterm are very, very likely to have high levels of stress. It's important to do a psychology or psychiatric referral and help these mothers to cope, because with the stress, the milk won't come. And however much we tell or try to scold the mother, it just is counterproductive. So it's important to make sure that these people are supported adequately. So we need to know the correct technique of expressing milk, not only the nurse or the midwife, because you have to guide them. You cannot just rely on nurse and midwife to know this. So hold the around the areola with the thumb and the index finger, press back, count to 10 at least, wait for a little while, and bring it close in the same plate. Right? It may take half an hour to get half a drop of milk. So you can't sort of do it in 1 minute. It takes a little time. That's why you need a staff that is trained and people to help you to do this. But waiting this half an hour is very, very important for this baby. Just because we are in a hurry, don't write off a baby to get metabolic syndrome, obesity, and heart disease in the future. So antenatal counseling is important. So whenever we get the referral for a preterm baby, when we are talking about that the baby will need to get into an ICU, we should also say the mom will need to express, and breast milk is very important. Get the mother to come and see the baby because the feeling of belonging will help her to go on and express. Try to get the milk as soon as possible. So that for that, we need to talk to ICU or postnatal ward or high dependence unit, wherever the mother is close liaison with the staff there. And initial days, mom cannot do it by herself because these moms are usually sick. So we need to make sure we talk with the nurses, midwives who will need to express the milk from the mother. So only half a drop or 1 drop may come on the first day, but if we keep at it, even if nothing comes, every 2 hourly we must express. If we do this, then there will be little by little the milk will start to come. And as you can see here, when the uh, breast milk volume is about half the volume of the total requirement, we stop the parenteral nutrition, because babies who are 32 weeks or less, 1,500 grams or less, we start parenteral nutrition. By 3 to 4 days, we can stop it. When it reaches 50% of the requirement, we stop the parenteral nutrition. And when it's 75% of the requirement, we omit all the IV fluids. We advance the feeds as they become available. You shouldn't be scared to increase the fees. So there's nothing as first day 5, next day 10, next day 20. Increase it as they are available. Unless the baby is having necrotizing enterocolitis, you might go a little slower. So again, Cochrane review has shown that slow advancement does not reduce the risk. Actually, there are other studies which have shown that slow advancement, because maybe the clinicians are scared, actually is detrimental for the baby, because that means you are keeping baby on IV fluids for a long time, exposing the baby to more complications. So in order to be successful with getting enough milk for the baby, we have to involve the mother in the baby's plan, talk to her, congratulate her on amounts expressed, and observe her expressing technique, give her positive feedback, and we have to assist her to put the baby into kangaroo care and encourage the baby to nuzzle on the empty breast. So any baby who is on non-invasive support and who is not on an invasive sort of with the ET tube, we will give the mother skin to skin even as early as day 1. So we need to tell the, you need to talk to the mother, boost up her confidence, make sure she comes to the neonatal unit, even in a wheelchair, give skin to skin care. And we need to make sure her technique is correct, keep an eye on the milk volumes that she is expressing. And especially for babies who are waiting long durations in the postnatal wards, in neonatal units, we can ask them to go home and come daily while they express the milk at home and bring them on a daily basis. So we encourage them to go home and visit the baby daily, where they express every 2 to 3 hours in clean cups, label the expression time, transport in a cold box, and use them for the following night. So babies, especially preterm babies, small babies, cannot feed directly from the breast. So the milk is expressed, and this is how we feed through the tube. Feed has to go in about 10 to 15 minutes. So we tape it to the inside of the incubator after timing that it goes in 10 to 15 minutes. If the baby is not tolerating, we can give it slower through an infusion pump. So preferably within half an hour or maximal during 1 hour. It's important for the baby to have times where they are not fed and they can have a good quality REM sleep. And when they are ready, we start feeding them with cup. The nurses usually start. And when the baby is taking the cup feed very well from the nurses within 30 minutes or so, we allow the mother to do it. So here is a small video showing how to do it. So the cup should be somewhat full and keep it on the lower lip. Tip it so that it actually touches the baby's upper lip and get the baby to feed. and we allow the baby to nuzzle on the breast. And what do we really do if there's poor weight gain? So first thing, look for a medical complication. Has a PDA opened up? Is the baby too distressed on the current mode of ventilation? Maybe you need to step up. Is there a new infection? Then look for the adequate volumes of breast milk. That is the most important thing. Is the hind milk being given? So make sure the mom is emptying the breast. Express into 2 to 3 cups. Give the last cup first. And the other problem is the baby getting too tired? Moms are frequently very excited when babies are better. They want to feed for a long duration, but baby gets very tired because they are small. So limit the breastfeed. So the direct time on the breast to about 10 minutes. Express the rest and give it through the cup. If it's taking long time to feed through the cup, you may need to give some with the NG tube as well. So if the milk volume is decreasing, it is due to our problem, not the mother's problem. So in order we need to talk to the mother, boost her confidence, ensure that she is emptying the breast regularly, maybe as frequently as 2 hours. You can see the prolactin increases with frequent stimulation to the breast, and inhibitor decreases when we empty the breast. Ensure that expression occurs too early in the night, and make sure the mother is brought to the PBU in the night between 12 a.m. and 6 a.m. Because this is the time people are lazy to get the mothers down. So it's very important that mothers are brought and mothers feed during this time. They can rest either before or after. Increase the skin-to-skin contact, get the mother to touch and talk to the baby, and make sure the baby suckles on the empty breast. So we are talking about prolactin, which comes from the anterior pituitary, and oxytocin, which comes from the posterior pituitary. And having the mom sort of in a confident situation where she is given positive feedback is important, because negative thoughts will inhibit the oxytocin. And this I'm showing you, this is so little 1 or 2 drops of colostrum is enough for small babies, because their tummy size on day 1 is the size of a cherry. It takes 1 month for their tummy to be as big as an egg. But nevertheless, the tummy is stretchable. So if we pour down gallons of formula onto it, it will keep expecting that. So in our unit, as early about 10 years back, we saw that most babies were started on breast milk alone, and they have got good weight gain and good discharge weights, and their hospital stay was not prolonged. And this is a more recent study done about a year or 2 back, and it showed extreme preterm babies were all breastfed, and they achieved their birth weight in about 14 days, where full feeds were achieved by about 10 days. So these are some of the pictures of our preterm babies. These were all born around 26 weeks with 500 to 600 grams. So the guy in sunglasses is a term baby, and this is also one of our 26 babies. So if the mother is not fit to feed immediately, if she's having postpartum hemorrhage or medically unstable, be patient. The baby usually has glycogen stores for 2 to 3 days if it's a term baby without any other problems. So express milk from the mother and send to baby, and we'll send the baby to the mother when mom is ready. So if there's delayed establishment of breastfeeding due to, look for all these things. Is the mother stressed? Maybe a psychological referral. Look to see whether there are placental remnants. Are there medical problems? We need to be patient. So just a little bit of the physiology is because the progesterone, it takes about 3-4 days for the progesterone to go down. That is why we get colostrum in the beginning. And with the uninhibited act of prolactin, that's when the milk starts to come in. But after about 3 months, the prolactin goes down. So it will depend on how much the breast is emptied. There are really very few contraindications to breastfeeding. And with regard to drugs, it is limited to chemotherapy and radiotherapy. So anybody on any other drugs can actually be breastfed. And you should not go on the BNF. So the main cause for inadequate weight gain on breast milk is due to inadequate breast milk volume. Multiples can be breastfed, so you can see twins, but they should be breastfed simultaneously. And mom should be encouraged to wait until both babies wake up, because more prolactin when you suckle on both sides and more emptying when both babies suckle together. So most these are preterm twins who have successfully been breastfed, preterm triplets again successfully breastfed, and preterm quadruplets exclusively breastfed. So once mother is comfortable with feeding one baby with good technique, let's make sure that we support both babies at once with more suckling, more prolactin, more emptying, less feedback inhibitor. We have to also train somebody else in the family to support the mother to breastfeed, to how to hold, how to give the baby to the mother so it's easy for her to hold them, and also how to help her to express. And we would also train other family members to feed the baby express milk to the mother so that the mother is supported. So you must make sure that formula is not used, so making sure that formula is not freely available in the postnatal wards, and maybe what is available should be kept in the neonatal unit, and all the indications should be discussed with the consultant, and make sure that you are not liberal with dispensing formula. So the last bit on breast conditions, we should not do antenatal management for flat or inverted nipples. It is of no use at all. So encourage the mother, whatever the nipple she can feed, because milk is not made in the nipple. Nipple is only a delivery mechanism. And once the baby is born, maybe a bit of extra time is needed, because with more conditioning, the nipple will be drawn out when the baby touches the breast. So more skin to skin, and we may need to express milk in the first bit until the baby gets used to it. Then if there's a large nipple, just bend the nipple over so that it doesn't go and sort of, become a problem for the baby and it strikes inside the mouth. Just fold it over and allow the baby to attach. So these sort of babies where there are breast conditions, it is important to admit to your PBU or mother baby unit and support one-to-one. Again, if there are a lot of cracked nipples, that means the breastfeeding support is not really good. And we need to up our game. So make sure if a mother is complaining or making faces of pain, have a look. If there's a ridge, don't wait until it gets abraded and the skin is gone. Even if there's flattening of one side of the nipple, make sure that the baby's attachment is corrected. She can take any sort of drug for pain relief. Local application, we don't use antibiotics on it because it goes in the baby's mouth. Antibiotics should be given to the mother because this is a source of infection, and we have to correct the positioning and the attachment. So engorgement is if the whole breast gets involved, that is usually due to poor attachment. Mastitis is only when one part of the breast is involved. It's usually due to the way we hold it or too tight underwear, which is blocking one or more ducts. So for engorgement, analgesia is important. We should not use warm compression, and we should not empty the breast, because the more you empty, the more milk is produced. So these babies, we need to stick only to direct breastfeeding, and after feeding, we can use cold compression so that the edema goes down. Why not warm compression? Because it will cause vasodilation and increase the edema. And make sure that correct positioning and attachment is happening. And to improve the drainage, we correct the cause, meaning if it's tight underwear or mother is having a scissor hold, make sure she's holding and supporting positioning the baby appropriately. Massage towards the nipple, and we improve the drainage from the blocked duct. Again, antibiotics would be indicated for the mother if it is not improving within 24 hours. So it's make sure you need to keep these mothers under close observation and support, and make sure what you are doing is working. And if it doesn't really, we don't really address our mastitis, it will end up in a breast abscess, which would need surgical referral, incision, and drainage. Then again, there are a few things on rusty pipes. So there are other conditions where the breast milk will look like this, which we have published in our Journal of Child Health, but we can still continue to feed the baby, although because this is due to a problem with the duct and the milk is safe for the baby. Then there can be blood coming from the nipple, right? If it's painful, we have to look for cracked nipple, but if it's painless, there's a condition called duct ectasia, which is dilatation of the milk duct, which again, it is safe to continue feeding the baby. So thank you, and I would like to answer any questions.
Thank you for your excellent lecture, madam. So we have one question in the chat. I have noticed that mothers in postnatal wards are encouraged to feed every 2 hours at night. This exerts an extra stress on them. Is it a recommended method to feed every 2 hourly, or what are the alternatives?
Actually, no, we should not ask them to feed at a particular time. We have to ask them to look at the hunger cues and feed. So this feeding 2 hourly or 3 hourly should be discouraged. Now, in saying that, in the PBUs, we do have a sort of a time schedule when the babies are fed through NG or cup, because without that, it will be difficult for nurses to, manage a lot of babies. But in the ward, mom is only handling her own baby. So therefore, we have to actually discourage telling this 2 hourly, 3 hourly thing. And we have to encourage them to look for hunger cues. But there's a practical problem in the ward, because most of our postnatal wards, the cot is at the foot end of the mother. Now, in one of our postnatal wards at DMH, I have managed to put the cot on the side and move the bedhead locker to behind the bed with quite a lot of resistance, so that it is easy for the mother to see the baby. So I think these are some of the things we have to try and address, but we should encourage our nursing staff and midwife to do is, maybe wake the mother up if they see that the baby is waking up, but not really go at 2 hours and wake the baby up. I hope I answered your question.
Yes, madam. We have another question in the chat. Does we encourage breastfeeding after 1 year of age?
Yes, the national and the international recommendation is to go on till 2 years and beyond. So what we need to do is, actually we have to educate mothers on spacing the breastfeed. So the problem happens when, if they keep on continuing breastfeeding, say 2 hourly or 3 hourly. So the problem with going by the clock is this as well. So as I mentioned, the baby's tummy size increases and they are able to hold more milk with time. And when we start complementary feeding around 6 months of age, we should ideally replace a breast milk feed. So for example, around 4 to 6 months of age, baby's breast milk feeds should be around every 4 hours or so, 3 to 4 hours or so. So let's say the 6 o'clock breastfeed should become the breakfast. The 12 o'clock or 1 o'clock breastfeed should become the lunch. The 7 o'clock or 8 o'clock breastfeed in the night should become the dinner. And your 9 o'clock breastfeed should become snack 1, and your 3 o'clock breastfeed should become snack 2. So because of that, it is important that we encourage our patients to space the breastfeeding as well. Most of the time, our people, in our Asian culture, people say, "Andavan depa, baba andano kiri denna," and that really encourages babies to suckle on the breast, just to keep them quiet. So that causes a lot of unnecessary problems. So yes, we encourage to feed 2 years and beyond, but make sure that we also encourage them to space the breastfeeds and replace them with complementary feeds at the appropriate time. And once complementary feeds are started, we have to make sure that breast milk is given only after a feed, and around 1 year of age, it should be only 1 to 2 breastfeeds per day.
Thank you, madam. And we have several questions which we received in our pre-survey. So you have answered most of the questions, and few are left. Is low BMI contribute to low breast milk production?
No, actually the size of the mother doesn't contribute. Actually, a thin mother should be able to produce breast milk very well. Obesity is the problem. So the thin mother or small breast size doesn't impede breast milk production at all.
Second question, is it recommended to start complementary feeding at the age of 4 months or 5 months for a working mother?
Yes, it is. If it is at if it is at completion of 4 months, depending again on the mother's situation. Now, let's say the mother, let's say it's a doctor, and the doctor needs to go to work, say 8 to 4, and your traveling time to your hospital is 2 hours. So you're going to be away for a long time. So yes, in that situation, it is better to start complementary feeding. But if you are able to sort of do work a shift and you are most of the time with the baby and you are able to express milk enough for the time you are not there, you may not have to. So that depends on how long you're going to be away. Some women can work from home. Some women, your workplace is just, 5 minutes away. So those people can continue to breastfeed till 6 months. But if you're going to be away for a long time, then I would suggest, yes, start complementary feeding rather than starting formula feeding. So after completion of 4 months, yes, you can start.
Okay, thank you, madam. Third question is, any specific dietary recommendations to increase breast milk production?
No. No dietary things. I mean, there are Sri Lankan stuff that people do, koskanwa, blah, blah. So I don't say not to do that. They can go ahead and do that. That's all right. But there is just a balanced diet for the mom. That's it. And keep her happy. Don't put a lot of restrictions on the mom.
Then how to keep breast milk refrigerator for working mom?
Did I
The
answer
next,
your question?
yes, madam. The next question is how to
Yeah.
keep breast milk in the refrigerator for a working mom.
Right. Okay. So in the refrigerator, you can usually keep it for about 24 hours in the normal section, that is the bottom section. And if you freeze it in the normal refrigerator, we can keep it frozen for about 2 weeks. So actually for a working mom, I would recommend to start expressing breast milk around 2 weeks or 2 to 3 weeks before she starts going to work, maybe 2 weeks, and build up a stock, because you should not be expressing breast milk on that day morning for that day, the rest of the day. That will be very, very stressful for the mother. So what we should do is we should start building up a stock and then keep replenishing the stock. So if you have the opportunity to have sort of you express in a private room and keep the milk in the fridge until we come home, bring it in a cool bag, that is ideal. If let's say it's like a labor lady who doesn't have her own room and facilities to refrigerate, then you have to ask her to express the milk and discard. So yes, we have to label, make sure the container is clean with a wide mouth. You should not be changing to containers. So the cup you are going to use to feed the baby should be the same one you are going to express into. And hand expression is best, right? Do not recommend using any gadgets for expression either.
Thank you, madam. Then next question is can we give domperidone or maxalone to improve milk production?
We can, but again, not recommended to be given for all mothers. Again, you might want to use domperidone or maxalone once you have corrected the attachment, corrected positioning, make sure the everything of the breastfeeding technique is good, mother's mental situation is good. In that situation, once you have tried everything and still the weight gain is not good, or the milk amount of milk coming is very low, then you may start, but that will be around 1 to 2 weeks after the baby is born. So there is no indication to start day 1, day 2, day 3 babies on domperidone. So once you have exhausted all options by sort of helping them to reduce their stress and helping positioning attachment, then if it doesn't work, yes, there is a place for domperidone maxalone, but not to wholesale start. Because when I started working in my hospital, everybody was getting domperidone. That is very bad, because then without poor attachment, they are going to go into engorgement. So therefore, once you have done the basic things, and if there will be a couple of maybe very few mothers who need it, and once you have done positioning, attachment, and made sure the mother is sort of mentally prepared to do this after psychiatric referral or professional counseling, then there may be a place. Yes, but very selected.
Thank you, madam. Does breastfeeding affect teeth?
No. Well, as I said, it does. It has a positive effect on it. It reduces malocclusion, improves the jaw development. But in saying that, I'm repeating again, this breastfeeding should only be for the purpose of nutrition. We should not use the breast to console every time the baby cries. We should not use the breast to put the baby to sleep. Right? Sleep hygiene is something different. We have to maybe talk to the baby, give the baby a gentle pat, read a bedtime story, put some calming music. There are different things you can do to help the baby to go to sleep. Like, Nalavana business, putting the baby to sleep on our time schedule. Those are wrong things that we do. So when the baby is tired, encourage the baby to go to sleep. So because if you keep the breast in the baby's mouth all the time, it will get dental caries. So keeping the breast all the time is not good, but using it for feeds, so that will be 10 to 15 minutes or less, would actually help the teeth positively. But keeping it in the mouth all the time, obviously will have a negative effect with dental caries as with anything else.
Thank you, madam. Then regarding the breastfeeding in specific conditions, there are 3 conditions the questions has been asked about the absence of nipples, HIV infected mothers, and the babies born with cleft lip.
Okay, so I have not really come across anyone without this no nipple thing. I have come across ladies who have had burns on both sides where we could really not find a nipple. But that lady breastfed successfully. So the lady with the no nipple, we'll have to see. I mean, the nipple is not important, but if the areola is there, there may be some opening for the milk to come out. So we might have to feed and see what happens. Really, I really have not come across that. So I would need to read a bit more about it and get back to you for that. With regard to HIV, HIV, the recommendation is to give breast milk in any form, if possible. But we need to counsel these moms. There is a risk of, transmitting, especially if the control is poor. If the mother's CD4 counts if the mother is having undetectable viral loads and having good CD4 counts, then the risk of transmission is minimal, and the advantages of breast milk for the baby actually outweigh the disadvantages. Therefore, we would recommend breastfeeding, exclusive breastfeeding ideally, but it has to be a compliant mother who will come for follow-up, who will be seen in the hospital frequently, because we don't want her to get a cracked nipple that would increase the risk of transmission. So if the mother is compliant and willing to breastfeed, breastfeeding would be the best option. Even if she wants to do mixed feeding, that would still be better, but rather than not breastfeeding at all. Only thing is, once we start breastfeeding, we have to cover the baby with antiretrovirals for the whole period that the baby is breastfed. So if we are continuing to breastfeed for 2 years, baby's antiretrovirals will have to be continued for that duration of 2 years. That is the newest recommendation. About HIV, sorry. Cleft lip and palate, again, we start breastfeeding these babies soon after birth. And then we see how whether some babies can, because the breast will obliterate the cleft in the palate. So because of that, we start. So there's no need to admit everybody to the PBU and start IV fluids. So we start the baby on breastfeeds and under observation, and almost never have I seen a baby aspirate on the breast. But within the first couple of days, we have to also refer these babies to the orthodontic clinic, who will again assess and see. We have to look at the weight gain, because if the cleft is large and the breast is not successful in obliterating the cleft palate, we will need to use the obturator teat, which is given by the orthodontic surgeons. We should not express and give through the cup or the spoon. Right? So if the baby is unable to take the breast directly, we have to put an NG tube and feed the baby until seen by the orthodontic team. So I hope I answered that question about the different situations.
Yes, madam, thank you. What is the best way to give expressed milk to the baby?
That is through the cup or through the tube. Right? So it depends on the baby. If the baby can tolerate taking the cup, it's through the cup. If it's a very sick baby or very small baby or very preterm baby, it will initially be through the tube, and after that it will be from the cup in addition to the direct breastfeeding.
Next question, if the baby has not reached the birth centile, is there a place to give formula feeds until birth centile is reached?
Absolutely not. If the baby has not reached the birth centile, you will have to see whether there's a medical problem, and you have to optimize the amount of breast milk produced by the mother and the way that she is feeding. There is absolutely no place to give formula.
Next question, madam, indications for hospital admission due to breastfeeding problems.
Indications for hospital admission. Again, now if a mother comes back to us, now what we do is, anybody with a more than 5% weight loss, we ask them to come back to our clinic. Some people come, some people don't come. Some people come later saying either baby is having fever or weight gain is poor. So if a baby comes back with fever or jaundice, or if the baby is sort of still continuing to lose weight and not really we expect the baby to regain their birth weight by 14 days. So if that is not happening and the weight loss is getting more, you should admit and support these mothers. So any problem, if they come back with either fever or jaundice or poor feeding, mom being unhappy, baby not gaining weight, continuing weight loss, all those would need admission as well as support, breastfeeding support as well.
Okay, thank you very much, madam. So if you have any specific questions, you can email us at toffeeshri13@gmail.com, and we will forward that to madam and get back to you. So our sincere thanks to Dr. Nishani Lucas, consultant neonatologist, University Unit, the Soysa Hospital Women, and senior lecturer at the Department of Paediatrics, University of Colombo, for her excellent lecture and the precious time. Thank you again, madam. And dear participants, please fill the link in the chat box. Then you can receive your CPD certificate. Thank you.